So I'd like to present a prospective multi-center clinical trial on vision and refractive outcomes of a novel light adjustable lens. I am John Vukich. I am a private practitioner. By full disclosure, I do consult for RxSight, among others. RxSight would be the one that is appropriate for this in particular. So here's a data summary. This is a multi-center trial. This is something that was used as the phase 4 clinical trial maintenance uh, following approval. And so we're looking at a fairly large sample. This is over 1,100 patients that were treated bilaterally with the light adjustable lens and 378 patients treated with the light adjustable lens plus the LAL plus. Very even distribution of male to female between the two groups, very similar age distribution as well. In the light adjustable lens, the LAL, there was no prior corneal surgery in 72.5% of eyes. In the LAL plus, it was 72.5%, again, well matched. LAL eyes had 24% previous LASIK, 15% in the LAL plus. Previous RK surgery in the LAL was 3.5% versus 1.1% LAL plus. If we take a look at the two groups and look at the mean anisometropia, and this would be after the full treatment and lock-in, the LAL patient's mean isometropia was 1.06 diopters. The LAL plus patients had a mean anisometropia or difference in the refraction of 0.87 diopters. The proportion of patients who were 1.25 diopter or lower was 82% in the LAL plus, as opposed to 66.8% in the LAL. We're looking now at the patients who had binocular uncorrected distance visual acuity. Again, this is binocular, and there was no difference between the two groups. These patients performed virtually identically in that regard. If we look at binocular uncorrected visual acuity at best focus, the LAL plus LAL patients, 80% were J1 or better. LAL plus patients were 95.2%. So it's pretty significant improvement in the percentage of patients who were J1 in the LAL plus. We look at binocular uncorrected intermediate visual acuity. The observed mean was better in the LAL plus compared to the LAL. You can see the numbers off to the side here. This represents a statistically significant difference. If we look at binocular uncorrected near visual acuity, the LAL patients, the LAL plus patients had better uncorrected near visual acuity, and these were mean logmars of 0.087 in the plus patients compared to 0.17 in the LAL patients. We look at monocular uncorrected distance visual acuity. There was no statistical difference between the two comparisons of LAL and LAL plus. If we look at monocular uncorrected distance visual acuity, the LAL patients were 20/40 plus, and this was their mean uncorrected distance. LAL plus was 20/30. So the observed median uncorrected distance visual acuity in the near eyes was, this is in the near eyes now, was better in the LAL plus, so that there was less anisometropia and presumably better binocular acuity because of that. The residual manifest refractive spherical equivalent was lower in the LAL plus compared to the LAL. So the LAL patients had a mean manifest refractive spherical equivalent of about 1/4 diopter, or 0.207, compared to 0.176 in the LAL plus. If we look at residual astigmatism, the observed mean residual astigmatism was lower in the LAL plus compared to the LAL, and this was almost 1/4 diopter in the LAL patients versus 0.176 in the LAL plus. So what do we learn from this? When we talk about lens selection, the recommendations are consider the LAL for eyes that would have got a monofocal or a toric lens. Consider LAL plus for eyes that might be candidates for a broadened depth of focus with no ocular comorbidities or large angle kappa, and they are less likely to be targeted for significant myopia. Future studies are underway for mix and match options, looking at LAL and LAL plus in one eye and the other, or LAL or LAL plus with a multifocal. We'll look forward to seeing the results of this. We found that the adjustable lenses do provide a significant level of option for the surgeon and the patient, and we can provide optimal visual acuity in patients that meet their expectation.